Hey, Brian, I think we can get started.
I'm going to share my screen, by the way.
Okay. Good morning, everyone. Thank you for joining us this morning. My name is Brian McCready. I'm with the Clackamas County Prevention Coalition, and we have Dr. Ken Finn from Colorado here today to present on public health concerns around cannabis. Our other panelists today are Elizabeth White, a coworker who works also for Clackamas County Children, Family, Community Connections, Katie Knutson from Clackamas County Public Health, and Jamie Zentner with Clackamas County Public Health. The coalition has invited Dr. Finn to present evidence-based information on cannabis safety, the connections between opioids and cannabis, and concerning trends regarding youth use. After Dr. Finn's presentation, we'll discuss ways to promote positive youth development and prevent youth use through local action. I do want to recognize that this can be a controversial subject. I just want to emphasize that what we're focused on as far as the coalition is preventing youth use of marijuana and byproducts of that. After, you can put your questions in the Q&A section at the bottom of the screen there, and we will answer those questions at the end after Dr. Finn's done presenting. So with that, I want to introduce Dr. Ken Finn from Colorado. We want to thank you today for coming, Doctor, and I'll pass it off to you.
Thanks, you guys. I appreciate everybody that's here giving me the opportunity. Again, I'm going to just provide you a lot of information. It will be drinking from a fire hose. We'll try to cover as much ground as possible in the limited time. Just an FYI, this is a very abridged version of what my knowledge base is and the depth of what I normally cover. Just a brief background of myself. I'm a pain medicine doctor. I've been practicing in Colorado Springs for almost 30 years. And the reason I went down this road is because as a pain medicine, was seeing a lot of patients on high dose opioids, which is a problem, and I'll discuss, with high levels of pain and using marijuana for pain. So clinically didn't make a lot of sense. So I did a lot of reading and research and ended up here about 15 years later. My background, I'm board certified in physical medicine and rehab, pain medicine and pain management. I'm the current president of the American Board of Pain Medicine. I've been on their exam council for over 20 years, running test questions for doctors that want to take better care of pain patients. I served on the Colorado Governor's Task Force for Amendment 64 when we legalized marijuana for recreational use. I served 4 years on our state's Medical Marijuana Scientific Advisory Council. I speak internationally. I'll be going to Vienna to speak to the UN next month. I am the editor of Cannabis and Medicine, an evidence-based approach, with 70 authors from 4 countries in a year and a half of my life I won't get back. And also the co-vice president of ISAC, which is the International Academy on the Science and Impacts of Cannabis. So I hope everybody's buckling up. I'm going to try to cover a lot in a short period of time. Just disclosures, I do get some honorarium from public speaking and I get royalties for my book, and I can tell you it's not a great way to retire. You don't get a lot of money being an editor of a medical book. Here's the molecules I want to talk about. One is the natural tetrahydrocannabinol, or THC. The other one is the cannabidiol, or CBD. And the other one is dronabinol, which is the synthetic THC. And as you can see in around the 7 o'clock position, molecularly, they look very similar, but that's the area why they may work a little differently. And for any chemists or science people out there, that's the molecule. So the natural one is at the bottom. The one right above it is the synthetic THC, which has been around since the 80s. So as a pain medicine doctor, it can be very frustrating patient population to deal with. However, I've been doing this for a long time and I find it very rewarding. I mean, I have a lot of patients I've been taking care of for over 20 years, some 25 years. I know their kids, their grandkids, and we have a nice working relationship. This is an important slide to understand the difference between what is cannabis-based medication and what's medical cannabis. Medications are registered extracts. They have defined content. They can be called cannabis-derived or cannabis-based. The examples are Epidiolex, which is a natural FDA-approved cannabinoid or CBD that is approved for a very narrow spectrum of pediatric seizure. And the folks that actually fast-tracked Epidiolex through the FDA were the ones that wrote my chapter on seizure. Sativex is not available in the US, but is a natural THC CBD nearly 1-to-1 ratio that's used in Europe and Canada for spasticity associated with multiple sclerosis. Dronabinol, a semi-synthetic, nabilone is a synthetic that have been around for nearly 40 years, originally developed for chemotherapy associated nausea and vomiting and weight loss associated with AIDS and HIV. Medical cannabis, on the flip side, are parts of the plant, the flowers, the buds, the leaves, extracts, etc. Unfortunately, they're poorly regulated and tested for contaminants. So why do people go to the doctor? They go for hypertension, obesity, asthma, diabetes, etc. But in the top 20 reasons, the only pain diagnosis is knee pain, likely osteoarthritis of the knee. The other pain conditions and other medical conditions that are not in the top reasons people see their doctor are neck pain, back pain, neuropathy, headache, cancer, seizure, etc. I just want to briefly touch on this relationship between cannabis and opioids. Because they come from very similar systems. They kind of complement each other. And from a basic science and molecular perspective, I believe that there are components of the plant that may have analgesic properties just because of how it's supposed to work. They belong to the same kind of receptors in the body that modulate pain pathways. They are found in the same part of the nerve endings. They share pharmacologic profiles, including sedation or anti-nociception or pain relief. And actually, naloxone, which is the antidote for opioid overdose, has been shown to have effects on the cannabinoid system in several animal models. So this was a nice review of why people kind of look for use of cannabis. And by far, pain is the #1 diagnosis that people usually resort to use of cannabis from a medical perspective. This was a nice review of all of the reviews. I'm going to talk briefly about our opioid epidemic, and I'm kind of leaning more towards we have an overdose problem, not necessarily a drug problem. Going back in time, there's really not a lot of evidence that, and this is all peer-reviewed medical literature. I mean, earlier on in 2015, 14, 16, there was a data showing that medical marijuana states have a higher, have less overdoses, et cetera. But Keith Humphreys and Chelsea Schober from Stanford actually used the same methodology for that. Oh, pardon me, I'm having a computer issue. They actually showed that medical cannabis laws showed a nearly 23% increase in overdose deaths. Last year, a nice paper came out showing that there's no protective relationship between state medical cannabis laws and opioid overdose. Kind of goes against the grain of what the platform to legalize is that's going to help our drug problem, our overdose or opioid problem. Last year, about a year ago, the effect of having and owning a medical marijuana card on pain. So if you actually obtain a medical marijuana card, you actually have a higher incidence and severity of cannabis use disorder and no significant improvement in pain. And just on a personal note, full disclosure, I'm a registered medical marijuana patient in the state of Colorado. I was curious, full disclosure, I don't use, but I was curious on how easy it was to obtain a card, my medical marijuana card. I can tell you, I didn't make anything up. I need knee replacements because I'm very active. I've had 5 knee surgeries, and I was approved for severe pain in 60 seconds, 1 minute to win it. There was no physical exam, there was no MRI review, there was no medical record review, there was no visualization of the scars on my knees, even because it was a telehealth visit. I was never even asked my level of pain, which on a day-to-day basis is about 0 to 2 on a 10 scale. But I was approved for severe pain in 1 minute, which kind of underscores kind of the ruse in a lot of these medical marijuana programs. If you look at, again, I believe components of the plant may be helpful for analgesia or pain relief. But if you look at this paper that came out, if you want to see a reduction in pain levels, your blood levels need to be around 18 to 20 nanograms per ml to demonstrate an impact on level of pain. And if you look at that, that's a pretty high concentration. And generally speaking, 5 nanograms per ml is considered driving impaired. Although per se limits is a whole other discussion. I don't believe in them, but that's what Colorado uses as impairment is the 5 NGs per ml. But if you want to have pain relief, you need to have 4 times that amount in your system. I'm going to go back to this relationship between cannabinoids and opioids. If you look at the Youth Risk Behavior Survey data that came out a couple of years ago, the number one risk factor for an adolescent to misuse opioids is having ever used marijuana. There's other factors, of course, but the number one risk factor for an adolescent to misuse their opioids is having ever used marijuana. And I'm going to circle back to that data point when I talk a little bit more about youth use. And I'm going to talk about this next paper that came out of JAMA Pediatrics a few years ago. After 3 years of first trying marijuana compared to opioids, marijuana has a much higher percentage of addiction in adolescents. And I was very surprised about this data, and I'm going to outline that here in a little bit. There was another paper looking at adult opioid misuse. And Waddicker was actually a high school kid from the Midwest. They used a very interesting, intricate matrix. But the predominant predictor of an adult misusing their opioids is having used marijuana before the age of 18. So this kind of highlights and underscores the important point of delaying onset of use. If you look at Olson's study from several years ago, it's kind of a 3-year time frame seems to be the underlying theme in a lot of these papers. It was a very large study. They followed it with 34,000 people. Cannabis use increases your risk of developing opioid use disorder or opioid misuse. That was a number of 34,000. If you look at the fatality analysis roadside survey and National Roadside Survey data from a few years ago, drivers testing positive for marijuana were more likely to test positive for prescription opioids. Again, this relationship between opioids and cannabinoids is very clear. Look at the National Survey of Drug Use and Health, nearly 76,000 people over the age of 50. Past year marijuana use was significantly increased odds of having opioid dependence and past year non-medical opioid use. If you look at the international pain organizations, this is the International Association for the Study of Pain. About a year and a half ago came out, they scoured the medical literature and concluded that due to the lack of high quality evidence, they don't support the use of cannabis or cannabinoids for pain relief. Again, this is an international pain organization saying it's not working. The Australian and New Zealand College of Anesthetists, their pain medicine faculty, shortly, like within a week or two, came out with the same conclusion because the studies are just poor quality. So other national organizations, Australian Pain Society, New Zealand Pain Society, British Pain Society, European Pain Federation from a few years ago. Actually, I like their paper because they were the first organization to address potency. They don't recommend using products more than 12.5% THC content. And I hope we have time to cover the issues with potency, psychosis, and mental health coming up. They were also the first organization to talk about kind of the black box warning that we have between opioids and benzodiazepines. You shouldn't co-prescribe due to risk of overdose. They don't recommend using cannabis-based medications on patients taking high doses of opioids and benzodiazepines. National Institute of Healthcare in the UK also doesn't recommend it. I'm going to circle back to Colorado. This is some of our data going back, our opioid overdose deaths by county. And here we voted on medical marijuana in 2000 and implemented in 2001. 90% of the medical marijuana card holders, their primary diagnosis is pain. The platform to legalize is that if we use marijuana as medicine, it'll help our opioid crisis, our overdose crisis. And I live in El Paso County, which is about half kind of mid-slide, and the darker the color, the worse the opioid deaths are. So here is 2002, 2005, 2008, 2011, and 2014. And as you can see over time, our overdose death rates are simply getting worse. Going against the platform to legalize is that it's going to help our drug problem. And the CDC data, you can see the prescriptions are going down, but our deaths are going up. Clearly, fentanyl is a big problem with that. I think that the more recent data, there's 106,000 deaths in the past year. Here's the Colorado data. Again, going back to 2001, when we implemented medical marijuana, 90% of the patients using for pain, platform to legalize is going to help a drug problem. And we had de facto legalization in 2009 when the dispensaries opened up across the state like daisies. And then we voted to legalize in 2012 and implemented in 2014. And this is the 2019 data. And as you can see, over time, our drug deaths all across the board continue to go up. The 2020 data looks like the COVID curve. Fentanyl started to spin off. And here's the 21 data. They actually had to compress the the graph because of so much more overdoses happening. And if anybody can show me where on these graphs that our drug problems getting better because of marijuana, please send me an email. I'd like to have that discussion. In Washington, D.C. now, you can self-certify without a doctor's supervision or certification that you're a medical marijuana patient. That happened around July of 2022. And look at the number of medical marijuana patients in D.C. after you don't even need doctor supervision. They kind of almost doubled. Archie Blyer and Brian Barnes from Oregon helped me. I was a contributing author. Archie was the primary author on this paper we published a year or so ago, looking at overdose deaths, kind of across the board in all the states that have done it. And interestingly, we know fentanyl has spun off into its own thing. However, the fentanyl death rates are much higher in marijuana states compared to non-marijuana states. All these drugs play very well in the sandbox. And I mean, I'm a very visual learner. And if you look at this graph, you can clearly see that medical marijuana implementation and expansion of these programs are going to lead to higher fentanyl death rates. In your place, Oregon, prescriptions are going down. Awesome. You're doing the right thing. I think the opioid crisis is on everybody's radar. Doctors are reluctant to prescribe. We try to follow CDC and state prescribing guidelines. But your drug death rates are going up as well, significantly worse since 2019. So in Oregon, I don't see where your expanded marijuana programs are helping your drug crisis either. Here's the paper that Archie Blyer and Brian, they're at the university in Portland. One of the reasons to expect marijuana is to help opioid dependence and mortality. However, unfortunately, death rates have gone up. And this is very frustrating for me because going back to the basic science, it should work. I mean, there's evidence that there's anti-nociception or pain relieving qualities to cannabinoids, but when you translate that into real world data, it's just not happening. I'm going to summarize the opioid issue before we shift gears. Currently, there's no evidence supporting the use of dispensary cannabis for chronic non-cancer pain, no evidence of substitution of opioids with dispensary cannabis. Again, dispensary cannabis is very poorly regulated and tested. There's no package insert for dispensary cannabis. Cannabis users are more likely to develop opioid use disorder, misuse their opioids, and have negative mental health effects. I'm going to talk about pregnancy and in utero exposure. So everybody take a little breath. I know it's a lot of information. This is a picture that speaks 1,000 words. This was used with permission from a police investigation in Colorado that had nothing to do with marijuana, but as part of the investigation led to this a storage facility that a Polaroid in there showed a person holding a fully locked and loaded marijuana pipe to an infant's face with a nutrient bottle at the wayside. If marijuana was a medicine, I'm going to give you a few data points. It would be pulled from the shelves if it was any other medication. So in Colorado, 70% of the dispensaries recommend use of cannabis during the first trimester. And we know that during lactation, THC can persist in breast milk for several weeks. And we know that prenatal marijuana exposure impacts executive functioning into a young adulthood. So the first data point, dispensaries are telling women use during first trimester for nausea. Here's the SAMHSA data that just came out last month. And if you look on the right, the graphic and the use of marijuana over time, either new daily use, the blue graph, has just continued to rise. Use of marijuana throughout the total pregnancy is on the rise. Use during first trimester is on the rise, second trimester on the rise. Interestingly, third trimester use has decreased. I don't know what the reasoning is, but you can see more women are using. Second data point, a lot of states don't track this, and I would encourage Oregon to look at this closely. Colorado, I can't find the data, but Connecticut published a paper a few months ago looking at substance exposed babies over a 28-month time frame. There was about 4,700 notifications. 3% were alcohol, 20% were opioids, but the vast majority of substance exposures were marijuana. So again, dispensaries recommend, babies are being more exposed. And what happens to those babies? If you look at the ABCD study that came out following those kids to middle childhood between 9 and 11 years of age, they were showing greater psychopathology characteristics with attention, thought, social problems, and what scared me the most, psychotic-like experiences. So I did a literature search. I mean, women use other substances during pregnancy, and was there any evidence of psychotic-like experiences to kids that were exposed to heroin or methamphetamine or cocaine or other illicits? I couldn't find anything in the literature about psychotic-like experiences in kids exposed to anything other than cannabis. NIDA just came out with a follow-up to that a few months ago. That's the National Institute of Health and Drug Abuse. Those kids were showing those problems that the ABCD study showed. Those problems persisted into early adolescence. You're talking about attention, social behavior problems. So what is going to happen to these kids when they hit young adulthood and beyond? And the animal studies show it's intergenerational. So these problems are going to persist to the next generation. Last month, early pregnancy cannabis and adverse pregnancy outcomes. You're talking about preterm birth, stillbirth, hypertensive disorders during pregnancy. So use during pregnancy is just not good, and we should caution women to avoid it. A few years before, because that was a follow-up study, cannabis use in pregnancy, higher risk of preterm birth. Interestingly, looking at 2,200 women who reported only using cannabis during pregnancy had a higher risk of autism compared to those that did not use cannabis. Stuart Rees from Australia published a very nice paper several years ago showing that medical marijuana states had an over 20% higher incidence of autism spectrum disorders compared to non-medical marijuana states. Fascinating data. And Susan Murphy from Duke University published some very good information on animal data that men who use may alter the autism gene. So you can't just point the finger at the mom all the time. Parental use or father use may be a problem. Last year, we were showing in Colorado, if you have more dispensaries, you have more pregnancy-related hospitalizations, a twofold increase between 2011 and 18 here. So the recreational market may actually influence cannabis use upon pregnant women. Okay. I'm going to shift gears again, talk a little bit more about adolescent use and child poisonings. I would recommend that these things shouldn't taste very good to children that under the age of 5 or 6 years of age, because everybody says we need to keep it out of the hands of kids. But you can see in the Colorado data, the number of child poisonings has skyrocketed over time. And this is happening in every single state across the country, and actually is happening in Canada. This one, American Academy of Pediatrics, just came out last month. There was a 1,300% increase of child poisonings between 2017 and 2021. And that's when a lot more states were expanding their marijuana programs. And we know that a lot of those kids have problems with their central nervous system, and nearly 23% were admitted to the hospital. I think this was the data on child poisonings over time, 17 through 2021, a significant rise in kids under the age of 5 or 6 getting accidentally poisoned. This paper came out from Academic Pediatrics just earlier or kind of mid-year last year, and they looked at 52 children's hospitals across the country between 2004 and 2018. So again, a 13% increase or 13-fold increase in exposures in 18 compared to 2004. And the problem is that these children don't metabolize cannabinoids like the rest of us may. 15% required ICU care, 4% actually require mechanical ventilation. They're on an intubator. They're on a ventilator because of their cannabis exposure. And there's a fairly decent number of 645. The National Survey of Drug Use and Health and SAMHSA data, this data just came out last month, although they lag a couple of years behind. Youth use continues to rise. I mean, there's conflicting data that our adolescents are fine, they're not using more, but the data there really has shown some increases over time. If you're looking at past year marijuana only percent has gone up between 2016 and 2021. That's in the bottom left. Past month use, also on the bottom right, has gone up over time going back to 2016 and 2021. Monitoring the future data, we know that cannabis vaping is accelerating, and that's kind of what we're seeing in Colorado. Adolescents who report smoking and vaping nicotine and 10 plus occasions of binge drinking were significantly more likely to report 30-day cannabis use with vaping. So in Colorado, let me go back here. In Colorado, what we're seeing is, although the youth use rates may be static and stable, I think the kids these days are a lot more savvy and smarter than I was at that age. The behaviors are getting more dangerous. So in Colorado, in a 2-year time frame, we had a 70% increase of youth that were dabbing. And for those that don't know what dabbing is, it's combusting and inhaling very high potency cannabis products that are pushing 85%, 95% THC. So very, very potent products. We had a 70% rise in only 2 years of kids dabbing cannabis. We're failing on the compliance checks. Our Colorado Liquor Enforcement Division had 2,400 checks in 2021, where the Marijuana Enforcement Division had 80 underage checks. And the interesting thing is the marijuana has half the number of employees. Sam Wong, who's one of my authors as well, published some very interesting information. This is just after the cusp of legalization in 2014, although we did have de facto legalization in 2009. When a teen presents to the emergency department with a marijuana-related event, 71% were psychiatric related. And I can tell you that the data has just gotten worse since then. If you look at some papers going back several years ago, the Annals of Emergency Medicine, increased marijuana use after legalization showed an increased number of the emergency visits and hospitalizations related to acute intoxication. ED visits nearly doubled post-legalization of recreational marijuana. Advertising is an issue. The Journal of Drug and Alcohol Dependence, higher average exposure to marijuana advertising associated with higher average use, intentions to use, negative consequences. So advertising may contribute to increased marijuana use, et cetera. January of last year, 1 year of publicly displayed posts by retail cannabis companies on Facebook and Instagram from 4 states. Despite state-based advertising restrictions, recreational cannabis business pages send messages that appeal to youth. If you're looking at the emergency room department down in California, they are seeing in San Diego only 37 marijuana cases a day, mostly psychosis. Teens in this is older adult. This came out just last month. Not just talking about adolescents, but you look at the geriatric population, there was a 1,800% increase in elderly patients presenting to the emergency department. So with more expansion of use, you're going to have more problems. Here's the number of older people going to the emergency department. Cannabinoid hyperemesis syndrome. I don't know if you've heard of this term before, but another term is scromiting. This came out a couple months ago. Problematic cannabis use and cannabinoid hyperemesis syndrome increase across all ages, from 15 ED visits per 100,000 to 21 after legalization, and then 32 beginning of the pandemic. So that's another problem, and it is kind of a bidirectional relationship, which I'll get to. I'm going to circle back to the adolescent cannabis and opioids I talked about earlier. This came out a couple of years ago. So if you look at within the first year trying marijuana, I'm going to slow down here. 10% of adolescents, early onset, you're talking about 12 to 17 years old, became addicted to it. Within 3 years of first trying the drug, 20% became addicted to it. And if you compare that to opioids, they had very similar data at the beginning and less at the end. So I'm going to go to this slide, looking at the first line of the onset of use, 12 to 17, and compare that to the third line of opioids between 12 and 17. And after 1 year, they have a very similar addiction rate of about 11%. 3 years later, the cannabis early onset users had twice the addiction rate than the opioid users, which I found this data somewhat surprising. And if you look at the older persons, the late adolescent, early adults, starting line 2 and 4, cannabis to opioids, again, after 1 year, a very similar addiction rate. I thought the opioids would have been more addicted personally, but after a year, a very similar addiction rate. And then 3 years later, although not as high as the early onset users, but still a higher addiction rate with the cannabis users compared to the opioid users. I found this data somewhat fascinating. I did not expect to see that. I personally thought the opioids would have been much more addictive than cannabis. Depression, we know that there's negative mental health effects. There's JAMA Psychiatry from a couple years ago. People that have depression have increased risk of cannabis use, especially daily or near daily use. Self-harm and mortality is adolescent data. Cannabis use disorder is common risk marker for self-harm, death by unintentional overdose, and homicide among youths with mood disorders. And cannabis use disorder was significantly associated with non-fatal self-harm and mortality. And this is, I'm going to circle back to something I mentioned earlier. So this paper came out 2 years ago. If you look at adolescent prescription opioid misuse, there was an increased risk of suicide-related behaviors. And I actually had an email exchange with the author. I said, did you look at prior cannabis use or what have you? But remember, I talked about the youth risk, the YRBS youth risk behavior survey that came out. The number one predictor of adolescent opioid misuse is having ever used marijuana. So now, do we have an indirect pathway starting with marijuana use progressing to suicidality? We know that there's issues with use and suicide. This is a National Survey of Drug Use and Health. Higher rates of suicidal behaviors among youth that use marijuana in the past year compared to those did not. And youth with marijuana use disorder have higher rates of suicide ideation, suicide plan, and suicide attempt. Just last month, the Colorado Department of Public Health and Environment, frequent marijuana users and use associated with psychotic disorders. And again, this cannabis, opioid, suicide, psychosis link is becoming much more clear. Daily or near daily marijuana use by adolescents is strongly associated with development of psychosis, such as psychotic disorders, such as schizophrenia in adulthood. I found this interesting that the CDPHE would publish this information, but it's evidence-based. If you look at our teen suicide data in Colorado, marijuana is the most prevalent substance found in completed teen suicide. It never used to be that way. I've been following this information. Our state has done a very good job at keeping this very user-friendly dashboard. Going back to 2012, before we voted to legalize, alcohol used to be the most prevalent substance found in completed teen suicide. In 2012, interestingly, that was a tipping point when marijuana started to take the lead. And I can tell you that I've been watching this data for a long period of time, and every year it has gotten worse. Nearly 1/3 of completed teen suicides that do toxicology find marijuana, which is nearly double alcohol, which was number 2. And why is this? I mean, I think it's a bidirectional relationship. I mean, are kids using because they're depressed? Or are they depressed because they're using? I've already presented information that it's not good for the early onset users, the developing brain. And I think it's very important that you have this educational talk with kids because this is very dangerous, and especially if they have mental health issues. You can see on the left-hand side, kind of the circumstances around completed teen suicide are all circulating around mental health problems. Long-term cannabis use and brain. This came out last year. If you're looking, this is a very nice study because they followed people from the early 70s to middle adulthood, middle age, age of 45, with a 94% retention rate. And if you look at the daily to near daily users, they had an IQ drop of 5.5 points. And if any of you in the audience are old enough to remember, they removed lead from lead-based paint, partly because it dropped your IQ about 4 points, but this doesn't get any attention. And long-term cannabis users had a smaller hippocampal volume, which is the area of the brain that modulates memory. I'm going to touch base on a few other medical impacts. The heart. Robert Page was one of my authors as well. He did my drug interaction chapter. He was also the lead author on the American Heart Association paper on the risk of heart issues when you're using cannabis. That also includes sudden death, arrhythmia, heart attack, and stroke. There's very clearly outlined cardiovascular effects. Medical cannabis users have a 74% higher risk of rhythm disorders. That came out August of last year. They have more SVT, more PACs, more non-sustained VTAC. That came out with a different paper, August of 22. So in the process of trying to develop a universal informed consent for providers to have good conversations, open conversations with their patients to educate them that maybe you should be cautious on use of cannabis if you have a prior heart history, like a heart attack or stenting, et cetera, or a history of stroke, et cetera. Other cardiovascular effects, you have a higher risk for cardiovascular disease, the brain, covered that. Verbal learning and memory, this came out July of last year, are impaired by acute cannabis intoxication that can persist even after the intoxication is over. Working memory, decision making, we know that the cannabis can impact that. I don't have enough time to talk about the industry failures, but I did want to mention this. The Secretary of State of Oregon, I think, did a fantastic job. Thank you, Oregon, for introspection on their program. They did an audit in 2019, and they were only able to investigate 3% of stores and 1/3 of growers for compliance, which to me is a big fail rate. But they concluded that their testing program can ensure that the testing results are reliable, and they could not confirm that the products were safe for human consumption. If you look at some of the Texas data, if you have a child death related to neglect or abuse, if you look at the substance use by the perpetrator, either active use or past use, you can see by far when there's a dead kid in the state of Texas, marijuana seems to be much more prevalent than number 2, which is nothing, or number 3, I'm not really sure, which is tied with the usual suspects, alcohol, opioids are way down at the bottom, other illicits. Is this really big tobacco 2.0? If you look at the cannabis lobbying, this paper came out last year, 48% of the lobbyists didn't even disclose their funders' cannabis affiliation. Tobacco companies are heavily invested in cannabis, which is long-term expected. Here's some of the information on, home grows, I think, are just breeding grounds for illegal activity. In Colorado, as a recreational patient, you can have 12 plants, and I count way more than 12 in this marijuana bust. Why are the investigators, DEA, wearing hazmat suits? Well, they don't know what's on these plants. There's pesticides, antifungal agents, rodenticides. They don't know what is on these plants, so they have to protect themselves. Here's some of the pictures that I got from law enforcement with the elaborate electrical grids in people's houses. There's different wiring. There's tripping entanglement hazards for first responders. There's commercial grade growing. They take up a lot of electricity in people's residential homes. There's do-it-yourself ventilation. They're poking holes in the drywall for the ventilation. One of my DEA colleagues told me that, I didn't know this, the R rating, R30 rating is the time it takes to get out of the house. And there's no registry for homes like there is a meth registry. You need to, disclose that your house was a meth house before you sell or buy it. There's nothing along those lines. So they can patch this all up, make it look pretty, smell nice with fresh paint. But the R rating goes from an R30 to an R5 when you alter the structure so that you have less time to get out of the house. Here's some of the mold oozing out of the side and in the drywall, which isn't a good medium to grow crops. Here in Northern California, Google Earth, in the Shasta community, all those white dots represent, we don't know if they're legal. Hemp grows, marijuana grows, who knows? And they don't have enough law enforcement to patrol it. So here's some of the what they're finding at some of the grows, the bait dogs that they use in the cartels. They're destroying the environment. They're killing the wildlife. Miles and miles of irrigation tubing that they're diverting water where salmon don't spawn. I know it's very close to the state of Oregon. The pesticides, the trash, booby traps, snare wires, dead animals here in Oregon. They don't know what to do with the miles of plastic water line and the 4,000 pounds of trash. They had to helicopter it out. In Oregon, they don't know if those grows behind the high school are legal. If they're hemp, if they're marijuana, they don't have enough time or resources to patrol. They're in the national forest. The Dolan fire in 2020 killed a firefighter, 10 homes, 125,000 acres, cost $62 million, and started intentionally by an illegal marijuana grower. So I know I sound like a nihilist and doom and gloom, but I don't want to come across that way. So I think you need to have an action plan. Marijuana is not medicine, it's a plant. We have a lot of plant-based medications already. Aspirin, for a perfect example, comes from the bark of the willow tree. Digitalis comes from the foxglove plant. Taxol comes from the Pacific yew tree to treat breast cancer. So I think we should support drug development process for cannabinoids, including evidence-based dosing guidelines. Potency should be an issue. There should be a cap. The European data says that if you have more than 10% THC, you have a 5-fold increased risk of first-time psychosis. So I think potency caps should be part of the discussion, especially in the developing brain. I think you should eliminate home grows, breeding ground for illegal activity. You have to
Hey,
track.
Dr. Fenn, 5-minute warning. Just
Oh, perfect. I'm almost done. Monitor, publish environmental impacts, track healthcare utilization. I mean, I published a paper that one hospital here in Colorado lost $20 million just from marijuana-related emergency room visits. And if you take that number across the state, hypothetically, that's a $500 million price tag in 6 years, or $83 million a year. A lot of my state leaders can't spell P&L or profit and loss because all they talk about how much money they're making. But all the current legal drugs like alcohol and tobacco make a lot of money for their respective industries, but we know what the societal costs are. And people tried not to talk about the societal costs. Mandatory drug testing for all violent crimes. Keep it, protect your kids' brains, monitor their use closely, discourage vaping and smoking. I mean, we were in the middle of a vaping epidemic before COVID hit. Discourage use during pregnancy and lactation. Follow American College of Obstetrics and Gynecology guidelines, the American Academy of Pediatrics. Do drug testing on all suicides, including adolescents. I don't know if Oregon does it. I couldn't find it on your state website, but I think it's important data to track and publish. Marijuana driving related fatalities. Follow the science, not the money. It was the impetus to edit a medical book, which I don't think I'll do again, but I learned a lot. And again, it allowed me to become an expert, not by choice, in this issue, and what prompted me to found a nonprofit, Isaac. We have lots of videos from people all over the world. They're free. You can go to our website, register. You can pick and choose which ones you want to look at or watch, anywhere from adolescent use to vaping, which I find fascinating. We can talk about that another time. But I'm going to stop sharing right now and open up to questions, and I hope it was helpful. I hope it wasn't too much drinking from the fire hose.
Thank you, Dr. Finn. I know one of the things that I come across here in Oregon is, especially among parent caregivers and older adults who grew up through the 70s and 80s, to really get the point across that this is not the same marijuana as that was used back then by such a long shot. And I know you kind of addressed that potency, but that really makes a huge difference.
yes, Dr. Finn, could you talk a little bit about the potency issue?
Well, there's a lot to talk about. I mean, if you look at the European data, anything over 10% THC is a risk for first-time psychosis, 5-fold increased risk of psychosis, and that's 10%. And the average smoke bud flower in Colorado is about 17 to 20%. And then we have concentrates that are available in both the medical and recreational markets that are averaging 50 to 60% THC. And then you get into the world of dabs, waxes, and shatters, which are some touting 100% THC, 85, 95, nearly 100% THC. So these were really in uncharted waters. We don't know what the long-term impacts of these very, very high potent products are going to be. And if you look, and I've been compiling a lot of information of some of these violent crimes and mass shootings, there seems to be, marijuana tends to be kind of a common denominator in many of them. Kevin Neal, for example, was from Northern California, shot up a school, killed several people, and I have this toxicology, and there's only one substance. Ian David Long from California shot and killed 14 people at a bar in Thousand Oaks, California, and I have his toxicology. He doesn't have a history of mental health issues, but then killed a bunch of people. Clearly cannabis psychosis. Richard Kirk, right after we legalized, he gobbled up a bunch of edibles and shot his wife while she was on the phone with 911 trying to get her husband help, and he shot and killed her. And I have his toxicology report, and there's only one thing in his system. And there's example after example after example of acute psychosis, and these are just edibles. These are not the high potency products. So I always wonder when I read about a mass shooting or an unusual violent act, it's important that you do mandatory drug testing on these cases, because I would probably lay dollars to donuts that a vast majority of them you're going to see some sort of substances involved, and very often probably you're going to see cannabis involved. And the thing that makes psychosis so insidious and covert is that even though it may get out of your system, the vast majority of people that are using cannabis are not going to become a homicidal maniac. Don't get me wrong. But if you do develop cannabis psychosis, Most of those patients, that psychosis will resolve once you stop. Sometimes it can take weeks or even months for that to resolve, even though it may be out of your system. We do have examples of people in the emergency departments waiting for placement because mental health care and treatment in Colorado and across the country is sorely lacking and very difficult to get placement for these people. But they're being babysat in the emergency room for weeks before they can get placement for their mental health problems associated with their cannabis use. And then for those that they have what's called persistent psychosis. Sometimes it doesn't resolve. And cannabis has the highest conversion rate to bipolar disorder and psychosis than any other substance. And that was a peer-reviewed literature article in the Lancet. You can have persistent psychosis. So you may be tested 6 months down the road and your drug test will be completely negative. But the precipitant of your psychosis was your cannabis use. A perfect example is Laura Stack. I don't know if you're familiar with her. She's kind of one of my heroes. Her son, Johnny, committed suicide, jumped off a 6-story RTD building in Denver. There was nothing in his system, but he was diagnosed with cannabis psychosis a couple of months prior to his suicide, but he was clean, but his psychosis persisted and he committed suicide. So that's the thing that in my mind makes marijuana so covert and insidious, is that it may be out of your system, even though the psychosis and other mental health issues can persist. So it's important that you get a very, very detailed history on the patient or the person and their family members. Johnny, got his medical marijuana card at the age of 18 because you don't need parental consent. He wasn't old enough to get the recreational stuff, but the products are pretty much the same. And then he became the school drug dealer because he can get a lot of product. But he ended up dabbing high potency marijuana, became psychotic, and then became suicidal and committed suicide.
Dr. Finn, one question that we had was if your slides would be available. Are you willing to share those slides with everybody, or the?
Of course.
Okay.
Yeah, and I think my slides will be available, and I think I provided my email to the chat at the very beginning. If you do have any questions or concerns or want any more resources, I mean, consider me a resource. I mean, most of my, if not all my slides are cited. These are all science-based information. I don't want to sound like I'm pontificating or making stuff up. I'm just trying to connect the dots and provide educational resources for both community leaders, parents. I think it's important parents have that discussion with their kids. Again, these kids are savvy. They are so much smarter than I was at that age. And they know more about this space, partly related to social media. I mean, mental health is a very complex problem we have in this day and age. I think social media is one part of our mental health crisis that's happening across the country. But the thing that doesn't get discussed is our widespread use and expansion of marijuana as a potential piece of the puzzle in our mental health crisis. I think it's a very, very important piece that people need to have an open conversation about.
I think you addressed this a little bit. We have a question that thank you for the resources. Although it is drinking from the fire hose, there is so much to take in here. We are deeply concerned with youth use and are running up against the misunderstanding to the impact to the teens who use. The more we can increase our understanding, the better we can address this issue in our communities. Is there additional information about those who have existing bipolar disorders and then begin using cannabis?
Oh, that's a really good question. I mean, that's a, somebody asked me a really good question kind of along this line is, what is the profile? What's the profile of an at-risk person? And what I've, based on the medical literature, I would say it's a young male person with a history of mental health problems that is using daily or near daily. Those are the risk factors. I think those patients are dancing in the raindrops because you don't know how that's going to affect them. And even if if the percentages remain the same, for example, 1% of an adolescent becomes psychotic or suicidal based on their marijuana use, and you have 100 of them, one of them is going to go down a bad pathway. But with more expansion, advertising to youth, more access, more use, even if the percentages are the same, you have 1,000, there's 10,000, there's 100. I think the adolescent brain is really vulnerable because that is the target organ in marijuana world. Alcohol is the liver, tobacco is the lung. But I think the one resource I would I would suggest is Every Brain Matters is a website you can go to. They have a lot of resources for parents. Johnny's ambassadors, Laura Stack, whose son Johnny I talked about committed suicide. She has a lot of good videos on speakers talking on how do parents and adolescents and kids have good conversations about this, because you really want, it's a parent's worst nightmare when your child commits suicide. I'm sure it tears a family apart. And Laura has been one of my heroes. I don't know how she did it. Within 1 year of Johnny's death, she got her nonprofit up and running, and she talks all over the country to try to educate parents on things to look for and the things that she missed. I mean, she was eventually able to get into his phone, see all the pictures of the products he had, the texts that he was sending to his friends to deal drugs, and she had no idea. This knows no boundaries. It doesn't matter what color you are, what race you are, what religion you are, what socioeconomic status you are. It knows no boundaries, and it picks its prey at will, at random, and it's very hard. I've met too many parents that have been impacted negatively just over what is described as a plant, but it's not a plant anymore. As you mentioned, Brian, this is not what you and I. It's not the ditchweed you and I grew up with that was averaging 3 to 5%. I mean, this is really GMO product that is very dangerous, especially in the adolescent and the developing brain. It's very frightening, and it's important that parents are involved in these discussions. And the kids, again, they probably know more than the parent in a lot of cases, I would assume.
I think one of the things that Brian connected with the expert around teen marijuana use in Oregon, and sometimes we don't see in the data, like kind of a steady marijuana use among teens, but it sounded like that this expert said that there's possibly higher daily use among teens. So the kids are, maybe not the use the rate, but yeah. So if you could speak to that a little bit,
Yeah,
that would be.
that's what I was getting at earlier. Based on the Healthy Kids Colorado survey data showed that the youth use rates in Colorado have remained fairly static, but the behaviors are changing. The behaviors are becoming more dangerous. Again, we had of the static percent that said they were using, number one, they're using daily or near daily, and they're dabbing. And these products are very, very potent products. So those small number of kids that are still using are using much more dangerous products. And that's the problem. And the flaws with that data is that it's administered in the high school. And if you have a kid that's in drug treatment, they're not in school to take a survey. So I think that the data is somewhat flawed in that respect. And they didn't account for some of the larger counties, like where I live in El Paso County, which is the fastest growing county in the state, and other counties like Denver County and Jefferson County around Denver. I think they weren't included in that data. So I think the data is somewhat flawed, but at least they're trying to figure out how to address this issue in our high schools and colleges because of these behaviors that are changing with the potent products that are much more widely available, and the ease of access, for sure.
Do you have some data to share on the impacts of COVID on youth marijuana use? Because
I
we know it
do.
impacts mental health. We know it impacts mental health for youth, but kind of that correlation between all those factors.
I do. If you don't mind, I can pull some of that information
That would
up
be great.
on COVID. Bear with me here. There was COVID really had a negative impact on a lot of things because there was social isolation. I'm trying to find the slide that I use regarding COVID because, even though the kid may not be they may be home, their school may have been shut down, they were at home. I'm just trying to find this. Bear with me.
Yeah.
I apologize.
No, go ahead. So the data that we have from the student health survey, because it was an hard year, right, to conduct the survey data, and so it did show, didn't show increases in teen marijuana use, but we did see changes in teen mental health and suicidality. So if I think that's where we kind of connecting those dots for our community is important.
Well, I can send you some resources and some papers that, like during COVID, for example, kids were isolated, and there were some mental health issues, and I think there was a significant amount of kids that were using substances in isolation, which is probably bad for their mental health, because maybe mom and dad were still working, they were at home by themselves. They're old enough to stay home by themselves, but then they were using substances by themselves, including marijuana and alcohol, et cetera. And then they were using substances with their friends on Snapchat and other social media platforms. And then some were violating social distance guidelines and were, out and about using substances face to face. And I think, COVID really had that impact from a mental health perspective, just in and of itself, with the social isolation. But then you add substance on top of that, and social media on top of that. It was kind of a perfect storm to create a problem with mental health and with substance use.
Are you able to locate that slide? I didn't want to rush you.
Give me just a hot minute. I'm sure I can find it. Let's see here.
Yeah, well, while you're looking at that, just to let everyone know that Brian McCready is going to provide some information later on about our outreach project to cannabis retailers around securing your cannabis. That information that you presented about accidental poisonings is very alarming, but it will actually give us maybe some information to help move that conversation forward with cannabis retailers about encouraging their customers to secure their cannabis. So thank you for that information. I think that's really helpful for our community, since that's one of the things that we are continuing to work on, is to prevent accidental poisonings.
Let me see if I can pull this up here. I think it was, here we go. Can you see this?
Fantastic, thank you. Yes, we all are familiar with that.
Oh, with that? Yeah, for sure.
Yes.
So here's the global survey data back in September 20, respondents of 55,000. Significant number, 44% increase cannabis, 48 increase of alcohol. We know we had increased substance use, but alcohol and cannabis were by far the most. If you look at Canadian data, 43% increased their cannabis consumption during the pandemic. Past 3-month cannabis use significantly from 14% to 20% in that period, going between ages of 15 and 29. And one of the risk factors for COVID was substance use disorder, right? So they looked at breakthrough infections, and it was significantly higher for those with cocaine and cannabis use disorders. And I think in the adolescent world, I think I have some information about the kids and their marijuana use as a marker. But yeah, COVID certainly had a strong impact on substance use for sure.
Well, thank you so much for providing that information, Brian. Let's do some thank yous and housekeeping.
Yes, thank you, Dr. Finn. That was excellent. And I really appreciate your dedication to education. And I hope that today, not only the attendees, but the people that watch this later, that we can really start to get the community engaged in those conversations and trying to have those talks about what are we dealing with here in today's marijuana world, and especially how it deals with youth, because the industry's done such a good job of normalizing it and advocating for its benefits, and it's just the more and more data that you do and the rest of the researchers do help us to get a better understanding and hopefully change the tide with what we're seeing with youth use and the effects of that.
I just wanted to say, people don't leave. We're not done yet with this conversation. I just saw some people drop off, but yeah. So forgive me if it sounded like we were tying everything up in a bow.
Well, I think it's important to understand. We already have 3 legal drugs already. We have alcohol, tobacco, and opioids. And we all would agree that we haven't done a very good job with any of them. And these are addiction for profit industries. And now we've added another addiction for profit industry that's targeting our youth. It's really bothersome to me because the data is very clear. We haven't learned from our mistakes. We've done a better job with tobacco, for example, with colossal educational efforts. The perception of harm is up, therefore the use goes down. And I think it's really about messaging, like we talked briefly about advertising to youth, they're more likely to use. So we don't see the cigarette commercials on like the Super Bowl. We don't really, we do see alcohol. I think that's a whole other problem. That's why we have a lot of problem with alcohol. There's no cannabis commercials, obviously, but social media is ransacked with marijuana advertising. And I think it's going to take another colossal effort, particularly geared towards youth, to raise the clear indication that the perception of harm needs to be higher, because right now the perception of harm is very low. They don't think it's a big deal, and therefore the use is going to continue to go up. And I think what I've found, because I do speak to a lot of youth, and because they are so savvy, they're seeing what's happening to their friends and peers. They're seeing kids committing suicide. They're seeing their friends getting into car accidents over marijuana use. They see their friends that use marijuana attempt suicide, and they're much more attuned to it than I was at that age. And I think that's maybe one of the reasons or factors why the rates are relatively static, maybe creeping up a little bit. Not, the sky isn't falling like a lot of people thought it would, because I think the kids are paying attention and they're seeing what's happening to their friends and peers. The ones that are continuing to use are definitely using more aberrant behaviors with the high potency products and dabbing, daily, near daily use. Those are the at-risk kid, the young male, mental health issues, daily, near daily use. Those are the ones you have to target and really keep your finger on the pulse of that population for sure.
Well, that actually ties into our next conversation. And Dr. Finn, are you able to stay with us and participate in this conversation? If you're not, we thank you for joining us today.
Yeah, I have to leave. I have some more surgery to get to. I really appreciate the opportunity. And again, I have my email. Anybody has any questions, concerns, consider me a resource. I'm more than happy to provide the data that I have. There's more. Again, this was a very abridged version of what I normally can talk to. You barely scratched the surface. I mean, there's a lot more information and articles that I can provide in all these little spaces that really, to me, has created a problem from my perspective of concern, particularly for youth. I think that if you can delay onset to over past age 25 is preferable. I think you should support potency caps, because even in the adult, the high potency products are precipitating psychotic-like episodes and crimes of violence. And I think it's important that you follow the science and not the money, and really protect your communities. And I think Oregon has done a really good job, generally speaking. I mean, they're the only state to really put that report out on their audit. And I've been calling Colorado to do another audit. Their last audit was in 2009, and they made some changes to the medical program, which is failing dismally, and they won't do it. And I think states going down this road really need to be very careful on learning from Oregon and Colorado, Washington, and California's what we described as unintended consequences, because we didn't know that this was going to happen. We didn't have time to talk about, I don't know if we had time, at least not today, about isomerization and acetylation of products that are flooding the markets in many states. I think Oregon doesn't allow isomerization of hemp. At the last I checked, I think Oregon bans them. But there's other states like Texas and Florida, New Jersey. I mean, the Farm Bill has created another layer of public health threat, because what they do is they mass produce CBD from hemp, which is non-psychoactive, but through chemical processes, they can manipulate the molecule and create what's called an isomer. And several of the isomers of CBD is delta 8 THC, delta 10 THC, THCP, HHC, which is tetrahydrocannabinol, and they're all coming federally legal from hemp. And then they can take the delta 8 THC and acetylate it, and it's called THCO. And I'd recommend everybody go on Google and check out what THCO is, and they're very dangerous products. THCO was actually weaponized by the US government in the 1940s as a chemical warfare agent, because it eroded dogs' muscle coordination twice as much as conventional delta 9 THC. But these are all coming from hemp. So it was a loophole that needs to be closed. But I personally think that the industry knew exactly what they were going to what they were going to do when the Farm Bill was approved. They're going to mass produce CBD and make all these other isomers and acetylated products, and those are ending up in high schools across the country. They're convenience store products in Texas. You go to the gas station, you can buy. They advertise Delta 8 THC. Here it is. They don't have recreational marijuana in Texas, but they do have Delta 8 because it comes from hemp. It's a hemp product, but it's still THC. It's just a different isomer of the product. So I think isomerization needs to go away, and some of these other products need to be banned.
Oh, thank you, Dr. Finn. And yes, thank you for staying on as long as you can. I'm going to introduce Jamie Zentner, a colleague at Clackamas County Public Health, and we're going to continue this conversation. And I'm going to have Jamie kick us off with kind of more of an open discussion.
I hope it was helpful. You guys have a great day. Stay safe out there.
Thank you very much.
Bye.
Thank you.
Thank you, Elizabeth. And yes, thank you for thanking Dr. Finn. I'm going to share, oops. Sharing my slides. All right, you all seeing the slides here? All right, now we want it, this was really a lot of information Dr. Finn shared with us. Now we want to bring it local. How do we apply this information? And really what we want to do is bring the local conversation discussion to how do we balance destigmatizing cannabis use among adults while preventing use among youth. There are multiple perspectives to cannabis use, and regardless of where we stand on the issue, I hope we can all rally around and agree on that preventing youth use just has a whole myriad of benefits for our community. One of the first ways to address youth, to prevent youth use of cannabis, is to really name the factors that influence it. So thinking about our community, how many retail shops are in the community that are influencing use? What kind of access do youth have to cannabis at school or at home? What kind of just academic educational support do youth have to succeed in life? What's the family's economic well-being? What kind of adverse childhood experiences have youth had that now affect their mental health? Family history of substance use and peer use also influence youth use of cannabis. And really so identifying these factors that influence youth use is the first step in identifying strategies to really address it. And Elizabeth has pointed out that more investment in substance prevention funding has a significant influence on youth use in general. We can address all of these determinants of youth by applying a socio-ecological model. And really, when we apply strategies across the range, focusing on education and counseling on individuals to policies and community campaigns, applying a range of strategies is most effective in addressing youth use. Individual prevention strategies, as I mentioned, education and counseling, community campaigns, lock boxes in retail shops, and protective policies at a societal level. Brian's going to chat about social norms. You're muted, Brian.
Thank you, Jamie. So we got a lot of information from Dr. Finn. It sounds quite scary, and like the environment around us is, and it is. And I think that's one of the things with social norms, that we don't deny that, yes, we have a problem. we have a problem here with potency, with availability. There's so many different things. But one strategy that the Clackamas County Prevention Coalition has worked on, excuse me, in the last, 8-9 years is positive community norms. So what we've determined is through data, now this was data from the Clackamas Community College around alcohol use. This was before marijuana was legalized in Oregon. But the same is pretty much true what we found with marijuana as well. Excuse me. And that is, the perception is that among teens and college students is that most youth are using. But when we look at the data, the surveys we do at the college, the surveys we do through the Oregon Student Wellness Survey, what we're seeing is in actuality, instead of 3 out of 4 that are using is what the perception is, it's really more like 1 out of 4. Now, as Dr. Finn, as we've been discussing, 1 out of 4 is a significant problem. But what social norms really determines is that if the perception is most of students' peers are using, then the likelihood that they'll start using is higher. And that is because they want to fit in. They want to feel like they're accepted in a school environment, especially when you look at youth that are coming into high school or coming into middle school. They want to figure out where they're accepted and where they can feel like their friend group is going to be there for them. So we go into the schools. We have students do assignments to create positive norm posters. We put them up. We have them on our website, and we have actually a subgroup that meets that anyone's welcome to join or ask me some further questions about that, about going into schools and communities, service clubs. We take the voting devices in there so they can vote on what they perceive as the problem, and then we show them the data, and that's why data is so important. That's social norms, and now we can move on to the next slide, please. And so that's one thing that we're really trying to say, hey, most youth don't use. The other project that we started about 1.5 years ago was the Cannabis retail project, where we've been going out and talking to dispensary owners. And we found some great material from Clark County Prevention Coalition to share with the retailers about the importance of securing cannabis. Dr. Finn talked about the edibles, the high potency edibles, and the dabs. This stuff is extremely dangerous for teens all the way down to toddlers. So what we're trying to do is work with the dispensaries that they would be able to supply lock boxes for their customers at a low cost and have these cards available for customers as well. So there's actually 4 cards. We only are showing 2 today. But again, the thing that we love about these cards is that they were vetted by marijuana retailers in Clark County. And so as we've gone out to the dispensaries in Clackamas County, they've really liked them, and it resonates with what they want to be diligent as being responsible business owners to give this option available to their customers. So that's the cannabis retail effort. That's also something, if you want to know more about, please email me and we will connect back with you to see how you can help support that and work with us. Thank you.
Thank you, Brian. I'm going to round us out by introducing some policy considerations. There's this concept about public consumption of cannabis, and what this really means is being able to use cannabis legally in lounges, events, and production sites. Some version of public consumption exists in Alaska, California, Colorado, Illinois, Massachusetts, and Michigan. In Oregon, in the last two long legislative sessions in 2019 and 2021, there were two House bills introduced and considered seriously. There were a couple of hearings, multiple hearings on these two House bills, which would have allowed public consumption of cannabis. Cannabis advocates say that it would make use more equitable by allowing low income, well, just renters in general, to have a safe space to use, which could be true, which is true. But there are also there are also some trade-offs to that. And what public health is doing is looking at, we're completing a health impact assessment that asks, what are the health, equity, and social impacts of allowing public consumption of cannabis? We are very happy to entertain more conversations in the coming weeks when this report is released, but I'll leave you with some potential mitigation strategies if public consumption were legalized in Oregon. There's a lot of new research and evidence that shows secondhand cannabis smoke is toxic, just as toxic as tobacco smoke. So not allowing smoking and vaping indoors, instituting some zoning requirements, applying an equity lens to develop and regulate and evaluate public consumption of cannabis, earmarking cannabis tax revenue for prevention intervention strategies, and partnering with the Oregon Cannabis Research Center to provide more evidence of the impact of cannabis. These are new novel policies allowing public consumption of cannabis, and because it's new and novel, we don't have a lot of evidence as far as what the potential impacts could be. Now we'd like to open it up to everyone and just learn from you all. What are you doing in your communities? Whether you're here locally in the metro region or across the state, what are you doing to prevent youth cannabis use?
So Scott, if you could make it so everybody can be on screen so they can raise their hand and we can see them.
And this
Yeah,
is also an
I don't have the ability to put everybody on screen, but if anybody raises their hand, I certainly can allow them to speak to you.
Thank you. The chat is also enabled, so if you prefer to put something in the chat, you can do that as well. That was a lot of information that Dr. Finn presented, and if anyone wants to just reflect on that too, as well as talking about what are some strategies we can use to prevent youth cannabis use, please feel free to chime in. Ooh, look at Jessica raised her hand. Thank you, Jessica.
I did. Can you all hear me?
Yes.
Great. So hi, this is Jessica Duke. I manage the prevention unit with Clackamas County Children, Family, Community Connections Division, work closely with all the folks I see on the screen. But I really appreciated when Dr. Finn said that youth know and are aware of what some of the ramifications of cannabis use are. They themselves have stories that are meaningful to them about perhaps someone who was using cannabis and then got into a car accident, or someone who was a cannabis user and unfortunately committed suicide and the impact on their community. So I really think that it's important that we listen to, learn from, and ask permission to share out those authentic youth experiences when we talk about the risks, because I think we have an uphill battle with cannabis from the perception of harm to what we know the harm actually is. For years, we didn't have research on the harm of cannabis. And that's part of the battle that we're facing, right? We didn't have sort of the level of research that Dr. Finn is showing, which is pretty recent research. So when we're looking at trying to increase the perception of harm to what the data shows the harm actually is, lifting up those youth voices with their permission about the consequences and experiences that they've had with harm of use or seeing their friends use is really important.
Jessica, it's interesting you said that because I was watching a webinar on effective messaging to youth for overdose prevention, drug prevention, and it was focused on overdose prevention, but it was talking about like youth get those messages around harm from each other, that's, like that's a lot of where they, get their perception. So I thank you for lifting that up. Is there anyone else that wants to speak, have a reflection? All right, Lindsay. Lindsay, go ahead.
This is Judy Trask. I'm the Malheur County Prevention Coordinator, and I think I must be coming through as Lindsay for some reason. That's interesting. Because I'm actually on my computer. So I came into this late and I'm really disappointed about that. And I hope I can watch the recording, but my interest is in getting these dispensaries on board. Malheur County, right on the Idaho border, per capita, at one time per capita, we had more dispensaries per capita than any place in the nation. And we're seeing a significant increase in youth use, and our dispensaries literally just look at us as the enemy. And we actually spoke with a dispensary owner at a chamber meeting not very long ago, and kind of thought, well, maybe we can get him engaged. Well, he's making $1 million. He's the newest one in the town, and he's making $1 million a month, grossing $1 million a month. And we have 12 or 13 and several more coming. So I guess helping with us on how to approach those dispensaries and getting them to work with us instead of being so, literally, they put some pretty rude remarks about our coalition and stuff on their websites.
Well, Judy, I would just really encourage you, maybe we can talk, you've got my number, and we can chat about it, about what we're doing more in detail, and see if there's a way we can, do a connection point with them, and learn kind of like what we've done here. But yeah, that's tough when the battle lines have kind of been drawn.
It has been really tough. We don't have support from, and they bring a lot of money into the community. So then we're fighting that also. The one thing that we are doing over here is we teach the tobacco, marijuana, and e-cigarette course, which is from Clear Alliance. And we have got that in most of our local schools from 6th grade on up. And so that's what we're doing to battle it now, that educational piece. But man, it's a problem over here.
Once we we're still in the process of doing our cannabis outreach project, once we kind of move that forward a little bit more, we'll have more information to share. But it seems like an opportunity with the information, the data that Dr. Finn presented on accidental poisonings. That might be a way that we can start having those connections with cannabis retailers, because we both mutually don't want to have, nobody wants to have youth poisoning. So as we move forward, that might be a way that we can build better connections with the cannabis retailers. So stay tuned.
Thank you.
Yes. Is there anyone else that would like to? Oh, go ahead, JB.
Judy, I was just gonna suggest that you tune into the legislative session in the events that additional public consumption of cannabis bills are introduced, how that could impact Malheur County based on what you're describing, just the number of retailers out in your area. The venues that could potentially turn into public consumption places might be of interest to your prevention coalition, your parents, local decision makers.
Thank you. Yes. And in saying that, most of the patrons of these dispensaries, I would say a very large portion of the patrons of these dispensaries are from Idaho. So if they open it up to use in the public, then that creates a whole nother problem for us over here in Ontario. And it's pretty tough as it is, so. Thank you.
Yes, is there anybody else that would like to speak on camera, or just speak, I should say?
I think Katrinka McReynolds is making an interesting point, likening the cannabis industry to what we want to balance with gambling.
Yeah, I mean, these are the issues that, this is why this is a collaboration between our, tobacco partners, is that, when we're dealing with legal substances, we just, it's a different approach, right, than we have with the illicit substances. So it's challenging, and education is a key factor of that. And we hope that today that bringing Dr. Finn helped, provide some of that education. And I would say, Brian McCready, why don't you talk about how, if people are interested in this and they live in Clackamas County or serve residents of Clackamas County, how can they become more involved in moving this discussion forward?
Yeah, so this is normally the day that our coalition meets, and this was in lieu of our coalition meeting today, but we always meet on the third Wednesday of each month at 3 o'clock. And so if you're interested in learning more about our coalition, about how we collaborate with public health, behavioral health, to do this work comprehensively, and various components of it, you can get a hold of me or Jamie. Our emails are in that last slide. And I am glad that everyone is able to be part of this today. So I just think it's a place where you can continue just conversations, whether you need somebody to come out and do a presentation at a Rotary Club or a school or something like that, or you just want to talk more about what the local condition is in your community and how we can help work with you and brainstorm how to help create awareness and lower youth use.
Yeah, so please join us and continue this conversation. We're hoping this is just one of many conversations that we're hoping to mobilize our communities to prevent youth cannabis use, alcohol, and tobacco use. So thank you so much. And I think we're ready to go. Brian, what do you think?
Yeah.
I think
Yes.
ready to sign off and let you have your afternoon. So thank you,
Yeah.
everyone, for joining us today.
Thank you so much for coming.
Thank you.